My name is Andrew Taliaferro, and I am a Chief Radiology Resident at the University of California at San Francisco. I will be discussing the utility and outcomes of preoperative screening breast MRI for planned prophylactic mastectomy in high-risk patients. I have no financial disclosures. Prophylactic mastectomy is an effective means of reducing breast cancer risk among asymptomatic high-risk women. However, up to 11% of prophylactic mastectomy specimens contain occult malignancy. This is problematic since these patients cannot undergo sentinel lymph node identification after mastectomy, which relies on injection of radiotracer and/or dye into the breast. Thus, some high-risk women undergo breast MRI before their prophylactic mastectomy to evaluate for occult malignancy. There are no established guidelines for preoperative imaging before bilateral prophylactic mastectomy, and breast MRI in this setting has unknown utility. The objectives of this study were to evaluate the utility of preoperative breast MRI in detecting occult malignancy before bilateral prophylactic mastectomy, and to determine whether preoperative breast MRI findings impact the decision to perform sentinel lymph node biopsy. As part of this IRB-approved study, a radiology report database was queried for breast MRI exams in asymptomatic patients with indication of prophylactic bilateral mastectomy between 2003 and 2020. All breast MRI studies were initially interpreted and reported by fellowship-trained breast radiologists in accordance with the ACR BI-RADS Atlas. Next, the clinical chart was reviewed for patient risk factors, MR findings and assessment, history of percutaneous breast biopsy and/or mastectomy, and corresponding pathology diagnoses. MR examinations were excluded if the patient did not undergo the planned mastectomy, if there was no BI-RADS assessment in the MR report, if the patient had prior history of unilateral mastectomy, if the exam was for surveillance of a patient already included in the cohort, or if the exam was for problem solving of a mammographic finding. Lastly, statistical analysis was performed. 53 patients met inclusion criteria. The majority of patients were ages 40 and older. 77% of the included patients had a known hereditary gene mutation predisposing to breast cancer, the most common of which was a BRCA1 mutation. Most patients had breasts with scattered areas of fibroglandular density and minimal to mild background parenchymal enhancement. The majority of cases in this study were baseline examinations. 58.5% of patients had a negative MRI, defined as BI-RADS 1 or 2. 41.5% of patients had a positive MRI, defined as BI-RADS 3, 4, or 5. Among those with positive MRI, 54.5% had an enhancing mass, and 45.5% had non-mass enhancement. Only 4% were given BI-RADS 3, consistent with our institutional practice of not regularly using BI-RADS 3 for MRI. We found that all 31 patients with a negative MRI, or 59% of the total study population, went on to prophylactic mastectomy, each with benign pathology. None of the patients with a negative MRI underwent percutaneous biopsy. 22 patients had a positive MRI, all of whom underwent prophylactic mastectomy. 13 of these patients underwent image-guided biopsy prior to mastectomy, yielding one case of moderate to high-grade DCIS. 9 of these patients underwent mastectomy without image-guided biopsy, yielding one case of invasive lobular carcinoma. Breast MRI before prophylactic mastectomy resulted in a cancer detection rate of 38 cancers and 19 invasive cancers per 1,000 women. Furthermore, breast MRI had 100% sensitivity and 100% negative predictive value, but limited specificity for breast malignancy prior to prophylactic mastectomy. 39 of the 53 patients in this study had a screening mammogram within 1 year prior to their breast MRI. 35 of these 39 patients had a negative mammogram. Of note, the patient with invasive lobular carcinoma and the patient with moderate to high-grade DCIS detected on MRI both had false negative mammograms prior to their MRI. 4 of the 39 patients who had a screening mammogram had a positive interpretation for calcifications or mass, each with benign histopathology. The one case of invasive malignancy identified in this study was an asymptomatic 54-year-old woman with BRCA2 mutation who had a negative screening mammogram 8 months prior to undergoing MRI. MRI showed a 12 mm mass in the right breast with fast initial and delayed washout enhancement kinetics, and a BI-RADS assessment of 4 was assigned. The right axillary lymph nodes appeared grossly normal in size and morphology on MRI for this patient. The breast surgeon opted for axillary sentinel lymph node biopsy at the time of mastectomy instead of percutaneous biopsy. Pathology revealed invasive lobular carcinoma corresponding to the mass seen on MRI, shown here at high and low power magnification. 2 axillary sentinel lymph nodes demonstrated metastasis with extranodal extension. The 53 patients who underwent the planned prophylactic mastectomy and the 6 patients who did not undergo mastectomy and were thus excluded from the primary study cohort did not significantly differ in breast composition, background parenchymal enhancement, genetic mutation status, personal history of breast cancer, or the presence of multiple risk factors. The frequency of undergoing the planned prophylactic mastectomy was higher in patients with positive MRI, though this difference was not statistically significant. There was no association between MRI results and the length of time from breast MRI to prophylactic mastectomy. We also found that patients with positive breast MRI were more likely to undergo sentinel lymph node biopsy than those with a negative MRI. In summary, MRI was 100% sensitive for occult malignancy before prophylactic mastectomy, with 100% negative predictive value. In our small cohort of 53 patients, MR detected 2 cancers, including 1 invasive malignancy prior to prophylactic mastectomy. MRI was also helpful in determining patients who need sentinel lymph node biopsy. Our results indicate that sentinel lymph node biopsy may be avoided in patients with a negative MRI. In those with a positive MRI, sentinel lymph node biopsy may be avoided after benign concordant percutaneous biopsy. Our study had a few limitations. The study had a small sample size. However, this is the first study to address breast imaging prior to prophylactic mastectomy. Data for this study were not acquired prospectively, and multi-reader retrospective imaging review was not performed. However, our results reflect actual practice at our institution. Thank you.